What's your first and last name?
Jeffrey Raskin.
How do you spell that?
Jeffrey Raskin.
And neurosurgeon?
Correct, yeah. Pediatric neurosurgeon.
Okay.
What was this child, baby, like when you first met her?
Zara was smaller. I think I met her almost right when she was born in the NICU. She was having continuous seizures in the ICU. And eventually they were able to get her, our epileptologists here were able to get her seizures under some control to about 10 to 15 seizures a day. And then we watched Zara until she got big enough, essentially, to sustain a surgery of the magnitude that she did.
What's the underlying cause? Why was she having seizures? What was wrong in the brain that caused this?
Zara has some sort of embryo dysmorphic condition where the right half of her face and brain didn't form correctly. She has some small defects, including a small eye. The palpebral fissure is shortened, and she has a slightly deformed right ear. And she has a hemispheric involvement with a seizure focus. So her entire right half of her brain essentially doesn't do anything but sees. But sees, yeah. And so to fit it in a diagnosis is hard because I don't think an official diagnosis has been made besides medically refractory epilepsy. Some people have conditions called hemimegalencephaly, Rasmussen's encephalitis. It's really neither of those two, and I think we're still waiting for pathology to tell us what the brain looked like on a pathological specimen point of view.
Zara had essentially two options. She could live as long as she was able to live, having 8 to 10 seizures an hour, which were getting more and more violent, or she could have a large portion of her brain removed. Those are some really tough options.
Yeah, they're hard for families to consider. I think initially we had talked about doing hemispherectomy of this child being a hemispherectomy candidate, and family was considering that, but no family yet, I think, has jumped right on board with that sort of treatment plan. But over time, you see what happens when half of the brain seizes continuously. There is no ability to gain any developmental milestones, and that is problematic for the child and very difficult to watch for the families. And I think that over time, people come around to discussing a large brain surgery like what we proposed. And the reality is that it's really not as bad as having continuous seizures. Having half your brain that's functioning normally is better than having a whole brain that functions suboptimally.
I mean, I think everyone's curious. Everyone wants to know, how will she be able to perform academically? What can one function with just half a brain? You're saying yes. So what will be some of the hindrances as she grows older, and what will be her abilities?
Yeah, if you operate earlier, then you get better results. Children less than 2 oftentimes are able to produce speech if they have a normal contralateral hemisphere, which she does. So I would suspect that she's able to walk and talk and learn, and there certainly are hemispherectomy children who do just that. Her brain had sort of atrophied from the continuous seizures. On the right side it had atrophied, on the left side it was actually looks very normal. And because it had atrophied, there's evidence that the right side of the brain never really innervated the left side of the body. Babies don't use their cerebrum at all. They use their brainstem reflexes and so on. That's why babies don't walk, is because they have no input from above. They sort of gain that ability over time. There's evidence on her MRI scan from looking at the brainstem and looking at these advanced imaging techniques that we did called diffusion tensor imaging that show tracts. And it shows the cortical spinal tracts from the right side of the brain never made it down to the left side of the body. So that means that her left side of the brain is innervating both sides of the body. And that's what we see with patients who have hemispherectomies. They oftentimes do have some deficits. And so it would be surprising if she didn't have some left-sided deficits. But that will manifest as maybe a brace on the ankle, and she'll be able to walk, or and definitely decreased use of her left hand than she otherwise would. So the hand is definitely affected, but oftentimes patients with hemispherectomies can make lead remarkable functional lives.
So you're calling it a deficit. What do you expect would be probably the deficit that would maybe be most obvious or cause most complications? A brace on the left ankle?
Yeah, a slight limp. They look like a mild cerebral palsy patient because that's what they are essentially. They have diminished use of the hand that's involved. In Zara's case would be left hand, and a slight limp with her left leg. But otherwise, I would expect her to have a good chance of making a reasonable attempt at walking and talking and going to school.
Explain how rare this surgery is. Explain how rare this surgery is.
Oh, this is a rare surgery because it's a rare child that's indicated for it. So, if children have strokes, perinatal strokes, or if they have conditions like I've already described, Rasmussen's encephalitis, hemimegalencephaly, any large insult to one side of the brain, then they can be a candidate for hemispherectomy or hemispherotomy. There's some surgical nuance to how you either disconnect the cerebral hemisphere or resect completely the cerebral hemisphere. It's not a very common procedure at all. Certainly in Indiana, this is the first one in 15 years. But in other institutions, high volume epilepsy centers, level 4 centers, just like this center is a level 4 center, they're doing 10 to 15 a year and sometimes more. And I think that population exists out there, and I think that we're prepared now to facilitate those sorts of large treatment plans for these refractory epilepsy patients.
If I understood you correctly earlier, basically the left hemisphere just picks up the load for the right hemisphere, with just a couple of minor exceptions.
That's right. And we know if you're less than 2, you have a pretty good chance of talking. Speech is one of the most difficult things to translate from one hemisphere to another. Not everybody has one-sided language dominance. Some people have co-dominance. But if you have a cerebral insult on one side, then usually that functionality is translated to the other hemisphere. And we don't understand why that happens or how it happens.
Are
It's
you-
because she's still 9 months old. If you tried to have a hysterectomy with a 5-year-old or an adult, presumably the brain's already developed and that doesn't happen.
Correct. Yeah, there are plasticity limitations to the brain. So speech is too. And then, so there are other limitations that exist.
Are you seeing any of those obvious signs, any adverse effects 2 weeks post-op?
This is my first time seeing her, so you guys have spent more time with her than I have after surgery. I don't know. Are you seeing any signs of any seizures or any problems?
No, not a single seizure.
Have you noticed any developmental gains at all? Lifting her head up or opening her eyes more?
Yeah. She's lifting her head. She's opening her eyes. Only she's scared after the surgery, So she doesn't move a lot.
Does she track you?
Yeah.
Okay.
Yeah.
Did she track you before surgery?
Yeah.
Oh, she can.
Yeah.
So for 9 months, Zara has seized continuously and has had trouble making developmental milestones that a 9-month-old would be able to make. By now, 9-month-old should be sitting up, using pincher grasp, babbling, and so on. But she's still very young, and she could make a profound improvement in her skills. And I'll suspect that at 6 months, she's already making really impressive gains.
All things considered, time was on your side here.
Yeah, definitely. And we knew about her for a long time. Some people may have operated earlier. I think for us, for this being the first case in a long time, and for her size, we wanted to make sure that, number one, we were safe. So we waited until she was of large enough size to undergo that type of operation.
And what can you tell us about her parents stepping up to take a risk like this?
Well, they've done a great job of taking care of a complex patient for 9 months, and they obviously love Zara very much. This surgery sounds like a lot, but I don't know, she doesn't look like she's had a big surgery. She looks very good. You can see her incision, and that's the only evidence to us all that she's had a very, very large life-altering surgery.
Barely though, her hair must grow so quickly.
Well, we do a minimal shave here at Riley, so.
Well, I mean, even where the incision.
Yeah, exactly. So we only shave a tiny bit around the incision, but then I'm sure it grew back fast for her.
You used the phrase "a pretty good chance" a couple of times. How long would it take to be able to say for sure, yeah, it looks like this is the deficit or everything's fine or whatever it is? How long do you keep monitoring?
I'll monitor her forever, yeah, until she refuses to come to the pediatric hospital.
So 30.
Yeah, exactly. I mean, these patients, so they have continuing problems. Zara doesn't have a shunt right now, for example. A shunt is a tube system that diverts spinal fluid from inside your head to outside your head where it can be absorbed. You do that in patients who lose the ability to absorb their own fluid. And we're worried about that, and we're watching her for that. So she's only 2 weeks out. She's by no means out of, like, our worry time. And I think that won't happen for, I don't know, a year or so. And then you can always develop hydrocephalus also, so we have to continue to monitor her. Anyone can have a seizure, even someone who's had a hemispherectomy. So she's not immune to seizures. Even if she is surgically cured by this surgery, she could have a seizure from the other side. So we have to keep monitoring her for all of these problems.
In terms of deficits as opposed to complications from surgery, when would that manifest, if at all?
Complications from surgery would have manifest already, and we have MRI from after surgery that shows that there's no complication from surgery. That sort of thing would be present in the form of a stroke, some sort of injury to the normal side of the brain that we did not want to touch, or a residual component of brain tissue. There's no meaningful residual component of brain tissue in her, and there was no injury to the other side. So from a surgical perspective, there was no complication. A deficit like her limping in the leg and her hand, we expect those. And also a visual field loss. So, you know, her visual field in her right occipital cortex is gone. So she will have to learn how to use only her left visual fields in both eyes. But because she's so young, she'll never really know that she was missing it, and so her brain will fill in the difference.
And speech presumably would wait until it's time for her to start talking.
Correct.
Yeah. Back on the complication of surgery, so the possibility of a shunt for spinal fluid, that's not a complication from surgery? What would bring that about?
That's an expected problem that we know from doing hemispherectomies in people since the early 1900s, is that for whatever reason, patients who have hemispherectomies, total anatomic hemispherectomy, which is what Zara had, 15 to 30% of those patients develop hydrocephalus. They develop an inability to absorb their own spinal fluid. We don't know why, but the treatment is a shunt.
So if that happens, shunt.
Thank you.
Do you have anything you want to say?
Thank you so much for taking care of Zara and doing a great job for us.
Yeah, you're welcome.
We can never forget that.
Well, you're welcome. I think it's a big team. It's not just me. There's a whole team of epileptologists and other doctors that support me, other nurses in the OR, anesthesiologists that make this possible. And they all ask about Zara every day too. So it'll be my pleasure to accept that on behalf of our team.
Thank you so much.
You're welcome.
Thank you.
Anything else?
What else do you think you wanted to go to the exam room or see any of the scans?
We had talked about earlier, and I don't know if this is possible with your
Yeah.
guys' schedules, but maybe like a mock exam or something?
Yeah, we can do a real exam because I have to do that.
Yeah, the first time since the surgery.
Yeah.
I
Okay.
can take that off.
Okay.
Thank you. Appreciate it.
Sure. Which room? I don't know. I guess any of those dark
One
rooms we
that's
can.
maybe a little bit bigger?
Oh, yeah.
Or just be willing to do it a couple different times?
Sure. Let me find someone to direct.
Oh, go on.